Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I'd like to discuss some more rules that hopefully will help you take care of your patients. Rule number 132. There is always another way. When you're thinking about the management or maybe the treatment of some of your patients, and you get stuck with only one option that may not seem very compelling at that point. A good example is when I see a patient that maybe possibly has a compelling story for a stroke or a TIA. Now, I've been in that situation before when the patient's physical exam is very normal, however, the story is somewhat concerning. And thinking back about the case, I was facing the possibility of going down the rabbit hole of working the patient out for a stroke. Now, although the story and the HPI may be concerning, the physical exam and everything else at this point seems to be very assuring. My option, number one, was to, again, go down the rabbit hole of CT, admission, maybe MRI, maybe labs, etc., for something that is very unlikely. And the harder I thought about the case, at some point I realized maybe I can just call the neurologist, see what he or she think, and kind of get an idea of how concerned I really should be about this. I realized at that point that before embarking on a $1 million workup that involves radiation, I can maybe just speak to a specialist who can help me out. This is also a specifically very good example in hospitals when the neurologist, maybe a pediatric neurology fellow, can actually come to the ER, examine the patient, and give their opinion. So there is always another way. Another good example that comes to play very often in the pediatric emergency department is when you're about to do a procedure with a patient that doesn't seem particularly cooperative. Sedation always comes to mind, but I always remind my residents and my trainees that sedation is a little bit of a big deal. Beside the fact that it takes a long time to obtain consent, perform the sedation, obviously it involves risk, it's very costly, but there's almost always another way. So trying something simple like calling Child Life for some assistance, maybe give some Versed, maybe some other distractions, but before you start and make a commitment for conscious sedation, it might be reasonable and it might be a good idea to try or think about other options. There's almost always another way. Another situation I can think of is prescribing antibiotics. So very often I see patients in the emergency department with a questionable bacterial illness. For example, otitis media that can be viral or bacteria, etc. A rash that may be cellulitis, maybe allergic reaction, and at this point it's just kind of hard to know. Option number one is prescribe antibiotics and not worry about it, but as we know, this contributes to significant antibiotic resistance, which is a big problem nowadays. In addition, the patient may suffer some side effects from the antibiotics, which is never really a great idea, but there's always another way. So one of the things that I like to do is something that I've learned called rescue prescription. So a good example, a 3-year-old with fever with an eardrum that looks infected but otherwise looks well, with a good mother or a good parent with a good follow-up, assuming the encounter is before the weekend and there's no PCP around, giving a prescription to the parent and saying something like, "Mom and Dad, here's a prescription for antibiotics. I'm not sure your son or your daughter actually needs it right now. Why don't you just provide pain medication, wait a day or two, and if the infection doesn't go away, the symptoms get worse, by all means, you can come back to the ER or you can just start the prescription because likely this is bacterial illness at that point." A rescue prescription is almost always a good option that allows you to delay and possibly avoid antibiotic treatment. So remember rule number 132. There is always another way. Rule number 133. Remember the triad. Knee immobilizer, crutches, no weight bearing. Add to that triad maybe follow up with orthopedics. This rule refers to the significant majority of patients that I see who come to the ER with acute knee injuries or knee pain. If you work in pediatric emergency department long enough, even in trauma center, you know that knee fractures are very, very uncommon. I've had my share of seeing a lot of trauma patients, especially in fellowship, and a fracture of the knee is very unusual. Most commonly, we see patellar dislocation, which is a fairly significant injury and very painful, However, most of the time, the patient who come in with acute knee pain or even chronic knee pain have a muscle or maybe a ligament problem. There's a lot of ligaments in the knee, the ACL, the PCL, etc. And the treatment for all these is almost always knee immobilizer, crutches, and avoiding weight bearing. Follow up with orthopedist is almost always a good idea. However, if the patient has complete resolution of their symptoms, I'm not sure that's actually necessary. But that triad comes to play almost always when a patient comes in with knee injury or knee pain, especially something that was initiated after a basketball game or sports game of some sorts, when the patient had knee injury that usually involves twisting or some other abnormal movement. There's almost always a ligament problem for which the treatment is a knee immobilizer, crutches, and no weight bearing. As I mentioned in the past, I usually get x rays on those kids, but I make it clear to the parents that this is likely a ligament problem, and other than swelling, which we can see with our naked eye, the x ray will likely be normal. So remember the triad of knee immobilizer, crutches, and no weight bearing. It's almost always the treatment for most acute and even chronic knee complaints in the pediatric emergency department. Rule number 134. Be ready to go all the way. This, I think, is a very good rule to keep in mind when you are initiating or considering initiating a workup on a patient. Again, always good to give an example. So very often I see pediatric patients or neonatal patients who come in with complaints of fever. Oftentimes the temperature is actually normal, but the parents measured temperature of more than 100.4 at home. I've been in that situation many times when one of my residents or maybe a medical student suggests, Dr. Ivan, why don't we just obtain some labs, maybe CRP and CBC, and see how it goes? And I think that's a fine idea. However, you always have to have a plan and be ready to go all the way. So if a 3-month-old comes in, afebrile, but parents complain of fever at home, and you're obtaining labs, what are you going to do with those labs if they look concerning? Maybe the CRP is elevated, maybe there's some leukocytosis. However, the patient in front of you looks well. The vital signs right now are reassuring. Sure, there's a complaint of fever at home, which I'm not dismissing, but you gotta be ready to go all the way. So if that CRP is elevated and that CBC is elevated, are you gonna do a lumbar puncture? Are you now gonna obtain urine analysis? Those are also issues you have to discuss with the parents prior to obtaining those labs. So the point of that rule is be ready to go all the way. Consider the tests that you're obtaining and consider what's going to be your next move if those labs or those tests look concerning. Be ready to go all the way. Maybe the patient will need an admission, maybe further workup, maybe a consultation of some sorts. However, it's always a good idea to have a plan and be prepared to take that workup a step further if need be. Another good example when that rule comes to mind is getting an x-ray on a child with very little concern for pneumonia, or maybe an x-ray on a patient that the parent requested an x-ray. So for example, if a patient comes into the pediatric emergency department with cough and fever, I'm not particularly concerned about pneumonia. However, sometime my resident or the medical student will suggest, Dr. Ivan, why don't we just get an x-ray on the patient? I think that's fine, but you gotta ask yourself, what are you gonna do with those results? Very often, chest x-rays by some radiologists come back with interpretation of possible pneumonia or question atelectasis versus infiltrate, etc. You gotta ask yourself, what are you gonna do with that results? You have to be ready to go all the way. Does that mean antibiotics? Does that mean admission, etc.? You have to have a plan and you have to be prepared to deal with those results. Another good example is the CBC and the CRP on a patient with, let's say, pyelonephritis. Are you going to admit the patient because of leukocytosis and a high CRP? Are you going to change the management based on those results? You got to be ready to go all the way. So next time, before you order that blood test or that CT or X-ray, remember rule number 134, be ready to go all the way. And that is it for today, guys. Thank you very much for listening. I appreciate it. I hope you like PEM rules and continue listening to the podcast. Let's review briefly what we learned. Rule number 132. There is always another way. If something doesn't seem right and you want to choose a path of lesser resistance, something that might be easier for the patient may involve less money, or less time, remember there is always another way. Rule number 133, remember the triad: knee immobilizer, crutches, and no weight bearing. It's almost always the right answer for most knee pains and knee complaints in the pediatric emergency department. Rule number 134, be ready to go all the way. Before you obtain those labs, that x-ray, that CT, be ready to act upon those results. If the inflammatory markers are high or if there's leukocytosis, what are you going to do with this? Does that mean you're going to admit the patient? Are you going to give IV antibiotics instead of oral antibiotics? Expect the worst and be ready to go all the way. And that is it for today, guys. I appreciate you listening to the show. I hope you like it and continue to check out further episodes. The outro for today is one of my favorite songs by another Seattle band from the 90s, Soundgarden. This is called Fell on Black Days. Hope you like it.